Hello friends, now I will be talking to you about acute coronary syndrome. I hope you have seen the part 1 of CAD video, you have already seen, I presume. So now in acute coronary syndrome, patient has come with severe pain chest, or how it come, let's see. What are the things what are included in acute coronary syndrome? Unstable angina, non-ST elevated MI, ST elevated MI. So when the patient of acute coronary syndrome come to us, first of all we do the ECG. In this, ECG is normal or ECG is abnormal. If ECG is normal, then it is unstable angina. If it is abnormal, okay, but there is no ST elevation, this is non-STEMI, non-ST elevated MI, and if ST elevation is there, then we call as ST elevated MI. In this, the cardiac enzymes level are normal, but in this enzymes level are increased. And what is the abnormality in ECG we get here? We get symmetrical T wave inversion, but remember there is no ST elevation we get it, ST elevation we get it, right? So we take one by one. First of all we talk about unstable angina. Unstable angina is also known as pre-infarct angina. How we define unstable angina? First of all, patient has angina at rest or with minimal exertion. Number 2, recent onset angina, last 2 weeks, fresh angina, or accelerating angina. What do you mean by accelerating angina? Patient has long standing angina, stable angina, but now what he says, doctor, for the last 1 year, before 1 year I was walking for, and when I used to I walk for 1 kilometer, then after 1 kilometer I used to have pain chest, but now for last few months I have started getting pain even on walking in 500 meters, and now the recent few days I am getting pain even after walking for 200 meters. That means he is having accelerating angina. So these are the criteria of unstable angina. And as I told you, ECG is usually, we are not getting any ST elevation. Second is non-ST elevated MI. Again, what a basic pathology of non-ST elevated MI. Remember, here infarction has not occurred. This is the wall of the left ventricle. In non-ST elevated, only inner 1/3 of the myocardium is infarcted. Okay. That's why previously we were calling this entity as subendocardial infarction. It was not a transmural infarction, but now the term what we use is non-ST elevated MI. In this case, in the ECG, we get symmetrical T wave inversion. Of course, we don't get ST elevation. That's why we call the term as non-ST MI, as non-ST elevated MI. Now, these two unstable angina and in these two conditions, management is almost same as acute MI, ST elevated MI. Okay, but there is one difference. In these two entities, we normally don't use thrombolysis. This is the only difference. Rest all management is same what we will going for ST elevated MI. So now I will be focusing on acute MI, which is nothing but ST elevated MI. Acute MI, ST elevated MI. We have some clinical classification of acute MI. The clinical classification goes like this. We have class 1, where we have spontaneous MI because of this is the coronary artery. Here we have a plaque, suddenly plaque ruptures, clot is formed. So we call a spontaneous MI class 1A. Class 2 MI, where there is sudden increase in oxygen demand or decrease supply. Increased demand classically is seen in any cause of tachycardia or arrhythmias. Decreased supply is suddenly there is coronary embolism, sudden decrease in BP or sudden increase in BP. They are the usual thing which lead to sudden decreased demand or sudden increase in the decreased supply. Third, sudden cardiac death. Remember, in acute MI, 25% people do not reach hospital, and about another 25% they die within first 24 hours. In nutshell, mortality is very high in acute MI in the first 24 hours. Then we have 4A. Here MI occurs after PTCA. That means his angioplasty was done and that lead to MI. Or 4B, where MI occurs after stent. 4B. Then we have class 5, which MI occur after coronary artery bypass graft. So these are the 5 clinical classification of acute MI. Okay. So we'll be talking, of course, when we talk about routine MI, we usually talk about spontaneous MI. Now let's see how patient of spontaneous MI come to us. Of course, this thing can happen anywhere else also, but I'll talk about the simple usual patient who has been brought to you in your emergency room with MI. How patient come to us? First of all, symptoms. Patient usually have severe pain chest, profuse sweating, patient may have maybe syncopal attack, the patient may be breathless, gasping for the air, or patient may even have altered sensorium. So severe pain chest, as described, squeezing, heaviness, radiating to arms, to back, to the neck, right? At time, patient may not have pain chest, but he has only these features. So we call this as painless infarct. Painless infarct. This is seen in around 10% cases, and this is painless infarct is common in diabetic patient or in elderly patient. We get painless infarct. Now, what you get on examination, signs regarding the pulse, heart rate usually increase because of excess of catecholamine, but or because of anxiety, because of pain, tachycardia is the feature. But classically, bradycardia, it is seen in inferior wall MI. Inferior wall MI is a classical feature to remember, bradycardia. And in interior wall MI, it's usually tachycardia is there. As far as BP is concerned, it may be high because patient is hypertensive himself, or maybe normal or reduce. If BP reduce, that means patient is going into cardiogenic shock. Then JVP may be raised because of heart failure, and there may be third sound, fourth heart sound may be there, and as patient is going into heart failure, then patient may have basal crepitations. There may be late systolic murmur. This is due to papillary muscle dysfunction. This is due to papillary. Papillary muscle dysfunction. This can be there. This is what we can see when the patient is brought to us soon after the onset of pain chest. Now, how to proceed, how to investigate. So, if we have to diagnose a case of MI, we need have diagnosis of MI. There are three parameters, three things to see: history of pain chest, ECG finding, or cardiac enzyme. There are three. We need at least two. Why two? Why not all three? I told you. Pain chest may not be there in around 10% cases. Then we diagnose patient having some symptom like this, and then we are dependent on the cardiac enzyme and ECG. Even at times, ECG may be normal in acute MI, and sometime, even in very early MI, enzymes may be normal. So now we talk about ECG. What we get in ECG? This is the normal ECG, T wave. The first finding is tall T wave. Tall T wave. It occurs within minutes of acute MI, tall T wave. After that, ST elevation. This is the ST elevation. ST segment elevation. It occurs in around 2 to 4 hours. Then occurs T wave inversion. T wave inversion in around 8 to 12 hours. Then Q wave comes. This is the Q wave. Q wave. It comes in 1 to 2 days. This is the ECG finding you got to remember in acute MI. Right? Then we talk about cardiac enzymes. Almost the first enzyme to rise is troponin T. It starts rising in 2 to 4 hours, and it stays there for about 10 to 14 days. Soon rises CPK-MB in around CPK-MB with red color. It starts rising in 4 to 6 hours, but it comes down in 2 to 3 days. Then around 2 to 3 days start rising LDH and come down in 5 to 7 days is LDH. Hence, troponin T test is always the best because it is the earliest to rise and last to go. But CPK-MB is very useful in reinfarction. Reinfarction is CPK-MB. Okay, so we have raised enzyme and we have ECG finding. So that means patient has acute MI. Now we want to locate, we want to find out which part of the myocardium is involved. So we again learn some basics about the blood supply of the myocardium as well as which leads are there in ECG. So septum and septum, anterior part of septum, artery supply is left anterior descending artery, and in fact this artery is the most common involved artery in coronary artery disease. Is the most common artery involved. That's why this artery is also known as widow's artery. Why widow's artery? Because as I told you, CAD is much more common in males as compared to females, and 50% mortality is there in 24 hours. That's why this artery is also known as widow's artery. And this artery is involved in around 40 to 50% cases. And this you can see in leads. Which leads we can see this? ECG leads are V1 to V3. Then we have lateral wall. Artery is circumflex of the left coronary artery, left circumflex. Lead are V4 to V6, AVL and L1. This is involved in around 10 to 20% cases. This is involved in around 40 to 50%. This is around 10 to 20%. And circumflex. And this is LAD. And if complete left coronary artery is involved, then we call as extensive anterior MI, anterior wall MI. When left main stem is involved, then we can see leads will be V1 to V6, AVL and as well as L1. This is usually when left coronary artery itself is involved. Then we have inferior wall. Right coronary artery involved in around 20 to 30% cases, and that we see in 2-3 AVF. 2-3 AVF. Posterior wall. Is again by right coronary artery, and this we see in V1, V2 where we get tall R wave. Tall R wave. The height of R wave is more than the S wave, depth of S wave. Tall R wave is a reciprocal changes. And the right ventricle is supplied by again right coronary artery. Got it? So now we are clear about what leads which are seeing. When we have talked about right ventricular infarction, then we always like to use right sided leads. Right sided leads. Now you must know what is the meaning of right sided leads. Whenever you are suspecting RV infarct, then what you do, you go for right head lead. This is the sternum, space, okay. So when we do the usual ECG, this is V1, this is V2, this is V3, V4, V5, V6. But when we talk about right sided leads, then this is the V1, this becomes V2, V3, V4, V5, V6. That means same type of leads we are keeping, but sequence is reverse. And right sided lead are used to look for the right ventricular infarction. What next? Investigation. Echocardiography. Echocardiography is essential to know about regional wall motion abnormality and ejection fraction, so that we can know about the pump failure. Okay. Well, we admit the patient in ICU. Now we start the management plan also. Patient is hospitalized in intensive coronary care units. First thing what I give is aspirin is given. It is an antiplatelet drug. Its action start within 1 hour and it reduces mortality by 30%. And with this we also add any second antiplatelet drug, ticagrelor or clopidogrel, or prasugrel. Okay. This is a preferred drug. So 2 antiplatelet drug should be given, especially if patient is diabetic, and especially if you are planning for stent later on, then you can even add prasugrel also, either of the drug we can give. And these, then we always add statin, beta blockers to control the heart rate, ACEI. What is the role of ACEI in a case of acute MI? It has, number 1, control BP, control congestive heart failure, or to treat heart failure and to treat hypertension. But it has got one more quality. It stabilizes the plaque, myocardium. It stabilizes the myocardium. It makes the infarct tissue firm. It makes infarct tissue firm. So it prevents the rupture of myocardium. These 5 drugs, they have definitely mortality benefit. That means when you use this drug, it reduces mortality drastically. Now other drugs that we use are nitrates. This is to control the pain chest, or nitroglycerin. We also give injection morphine, maybe IV or IM. When we give IV, it is 2 to 3 milligram IV, but we can give IM 10 to 15 milligram IM. Then the other supporting drug are, of course, you have to control the BP and you have to control the blood sugar. That is the additional thing that we do in these patients, right? This is the acute management. Now what else we do in these cases in acute MI? If patient come to you within 90 minutes of the pain chest, and if facilities are there, always further management is PTCA, that is percutaneous transcoronary angioplasty. It is the next best step after the drug therapy onset. Now how it is done? Well, as I told you, we do the angiography. We have done the angiography and you locate the plaque. Then you put a catheter. Catheter is here, and this has balloon. Now once you do the positioning, then you inflate the balloon, and this balloon will push the plaque like this, and now you take out the balloon. So you have opened the block, so called PTCA. At times what happen, you take out the wire and this plaque again come back. In that scenario, you like to put a metallic tube, so called stent. You do a placing of the stent. It's a metallic tube, and this metallic tube will keep the stent patent. Okay, so we call as stent. This is again a method to keep it patent. But soon they realize that stent itself being a outside foreign particle, it itself can induce the clot formation. That's why nowadays they are using drug eluting stent. So these stents they are coated with a drug which will keep it patent, and they prevent the clot formation. And what drugs are usually used to coat this stent? It is paclitaxel, or rapamycin. Also known as sirolimus. So these are the drugs that we use for drug eluting stent. Okay. It also has a huge mortality benefit, but you cannot do PTCA in those patients who have calcified or a calcified atherosclerotic plaque calcification. How to detect? Now what they do before they send the patient for PTCA, they do CT scan, electron beam CT scan, electron beam CT scan. By this they can know how much the plaque is calcified, and they use a score called Agatston score for plaque calcification. And if the plaque is calcified, the patient is sent for coronary artery bypass surgery. Okay. So this was when patient has come to you within 90 minutes of acute MI. But suppose patient has come, or you don't have any facility in any of the medical center, or time is taking more to reach this center, then you can use thrombolysis. Thrombolysis. This is used by streptokinase or urokinase. Okay, and the thrombus will dissolve the clot, and D-dimer are produced, which are nothing but fibrin degradation product. This is how you can come. But thrombolytic therapy is effective in around 40 to 60% cases. That's why now, without doubt, if PTCA is available and indication, this is far superior to thrombolytic therapy also. So now patient is hospitalized with us, and what is the, suppose PT said not possible. Why not? The plaque is calcified or diffuse artery is involved, fibrous. So you go for coronary artery bypass graft. Coronary artery bypass graft. It is done if left coronary artery main stem is involved or calcified arteries or diffuse arteries involved diffusely or multi-vessels are involved. Multi-vessel or triple vessel, to be more precise, triple vessel. But even in diabetic, two vessel involvement is again a indication of coronary artery bypass graft or bypass surgery. How it is done? Let's learn the basic principle, how it is done. This is the coronary artery and this artery is blocked here. Now what they do? They take a graft and they will unite the graft like this. So now the blood will go like this. This is a simple diagrammatic representation of coronary artery bypass surgery. Now what graft are used? The graft used are Lima, left internal memory artery graft. This is the best graft. Second is Rima, right internal memory artery, radial artery or long saphenous vein. As I told you, this is the best graft. It may last for about 10 years. This is the basic principle of coronary artery bypass surgery. So now patient is stabilized, we are discharging the patient, and when we discharge the patient should take aspirin, second platelet drug. Now before that, one thing I forgot. In all the patients, when in acute coronary syndrome patient was there, you should use, in addition to what we discussed, low molecular weight heparin, and we got GP 2B 3A receptors drug like epsiximab, tirofiban, eptafibatide. They are especially very useful after stent. They are very effective in preventing post-stent thrombus. They should be used. And low molecular weight heparin or heparin should be used in all cases of CAD when the patient comes to you in the ICU. So patient get discharged, we use 2 antiplatelet drug, beta blockers, nitrate, statins, and ACEI. Okay. This is how you are going to manage a case of acute coronary syndrome. In the next lecture, I will be talking to you about the complication of a case of acute myocardial infarction. Thank you very much.